Admission and or transition. But I think it's not just during admission. Our responsibilities to patients under whatever circumstance. People come to clinic, people come to do physiotherapy, people come to do counseling, people come to refill drugs from the pharmacy shops, people come to just get appointment and go home. We have a lot of responsibilities. They come across health workers in every situation. So I think it's not just admission. Admission is one aspect of what we do. In fact, sometimes, I mean, we are in the market, somebody will see you, you remember the hospital, sorry, this drug, they wrote for me, I can't find it. So we have large responsibility, and it goes beyond the hospital, beyond admission. So we'll do that, we'll look at it, and it's not, nobody is going to just lecture us. I'll tell us the moment we are going to do it. And then we will be brief on that, because the second session is in the first part, so that the second part we will learn as many things as we can from the instructors who have sacrificed to come all the way from Kano to teach us. So with that, I think I will declare this open and open the discussion. I think the organizers have allowed me to continue talking. So the opening of the discussion, I think what we are going to do in public health, there's what we call open space programming or open space events. So I'll just describe what it means. No, there is no agenda, okay? The topic we are going to discuss is our responsibility as health workers towards patients, simple. Now, it's open. We can identify areas that we can discuss from all of us. Anybody is free to give us an area, we note it, and then we discuss around that area. That is what is meant by open space. A community is asked to set agenda for whatever they want. The group will come and say, okay, this is what we want a warhol, we want a bit Latin. Now this is our own community. We want to look at our roles and responsibilities towards patients. So let's set the agenda. And I would suggest maybe a 5-point agenda so that we can now discuss it, go to town and talk about it. So it's open. The MC should help us with the mic so that if anybody indicate, and when you, please, if you are going to talk, you tell us your name, your department, so that we can see you in perspective, because whatever department we are, we care for patients. So it's open. We need to set agenda. What do we want to discuss? It's open. Okay. We can use this mic actually. No problem. Anybody, please, just anybody can allow it. Let's set agenda, please.
Assalamu alaikum, brothers and sisters in Islam. My agenda is our patients buying their drugs in the hospital.
Okay. So the importance of patients procuring drugs in the hospital. Okay, that's one. Procurement of drugs in the hospital. There are so many reasons why he's saying that, and we'll discuss it. Next.
Assalamu alaikum.
Alaikum assalam.
I'm Dr. Babak Rashid. My topic is the role of the healthcare provider to a terminally ill patient.
Okay, care for the terminally ill. Our role, care for the terminally ill. Very good.
My name is Tanjuma Bello. I'm a permanent nurse in the nursing department. Now, just as one of the senior people on the health table said, that somebody from us, amongst us here, lost his wife recently, that she was cooking and suddenly fell before they could come to the hospital. By the time they reached the hospital was going to sacrifice her death. So life-saving support of the state procedures of managing the patient who suddenly fall down. I want us to discuss that. if it is possible.
Okay, the topic is responsibilities of the Muslim health worker to his patient.
Oh, okay.
So it will be around there.
It's okay, sir. It's okay.
I'm sure the BLS case, it will take care of that. When somebody's lungs, I'm sure they will talk to us about it. Yes.
Assalamu alaikum wa rahmatullah. The name is Shito Abdelaziz from Department of Physiotherapy. Around this topic, the agenda I think we need to set also is in perception of my profession. That is to tell every patient that there is ability in every disability that an average human being has. That is one. Then two, as a Muslim, particularly to the Muslim patients, let us also educate them on those things that are important and obligations to them from Islam. For example, a patient who is bedridden, some patients will think that when they are bedridden, there is no essence for them to pray. So, to the last time, as we know, there are categories of people that prayer is exempted for. So, we need to also tell this to our patients. I think it will also form the basis for agenda here.
Okay, so in the perspective now, educating a patient is religious role,
Exactly.
Exactly. Even when sick.
Yes.
Okay. Yes.
Assalamualaikum warahmatullah. I'm Mariam Hamid from Department of Nursing Service. The role of healthcare provider in oxygen administration, because some of our brothers and sisters, when they are hospitalized and it gets to an extent of administering oxygen, you see some of them actually give up. They'll say there's no need to give that oxygen, things like that. They will some prefer to sign against medical care and take the patient home. So I think we should really discuss this. It's really a problem.
Okay.
Thank you.
Attitudes to oxygen therapy for us and even for the patient.
Yes.
Because even some of us, when we see that, we say, "Hi." So maybe we'll discuss our own attitude and then the patient attitude first. What oxygen therapy is. Any other topic? Okay, there's one more there. That's number 5. So I think because we're saving time, after that, yes.
Concerning how to reconcile orthodox medicine, Islamic medicine, and the modern medicine.
How do we come in there?
How to harmonize now the traditional medicine and then the modern medicine?
Yes, I had a topic for us as health workers. What we're putting to patients or what we're educating them.
Yes, especially the most concept that the traditional medicine, most people believe that is strictly Islamic medicine. And then how to reconcile it with the modern medicine.
Okay. Okay, fine. It's okay. So traditional medicine and orthodox. Okay. Right. So that's the mic, please, so that we can talk about them. Okay. The last one I would suggest for us is our own responsibilities to ourselves. Because we can be patient. I don't know how many of us have checked our blood pressures, blood sugars, kidneys, lipids. But amongst us, people die. So our own responsibilities towards ourselves. Because this body that we have is not for us, it's for our children, for the family, for the ummah. That's what God tells us. If you are given the knowledge, if you are given health, it's not for you. So our responsibility towards our own selves. Okay? Physician has healed thyself. I think that's how they call it. Okay? So I think we'll also discuss that. This mic is failing intermittently. Okay, it has intermittent failure, sorry. Okay, so our own responsibilities to ourselves, to health issues of self-health issues. So I would suggest that each of these areas, I will call them again. I think the battery is weak here. Importance of patients procuring medications from authorized, from the hospital. Please, Director of Program.
I think we have filled all the chairs. Can we lock the door?
Please, because we don't want distractions.
I think as chairman, I'm allowed to lock the door.
Okay.
So the first one is the importance of procuring medications
From the hospital, care for the terminally ill person.
That's the second thing. Then
Educating patients on his religious roles even while sick.
a lot of our patients don't know what they're supposed to be doing.
They think when they're sick, they go on holiday, no prayers, nothing. They just start
having breathlessness and nishi, and the people come and give money and go away. So we need to do that.
attitudes towards oxygen therapy. Attitude of both health workers, us,
And the patients and patient relations towards oxygen therapy, very important. Then watershed between traditional medicine and orthodox medicine. Okay? And then our own self-health responsibility. Self-health care for us, for our own selves. I would suggest we discuss each for like 5 minutes. Is it okay?
yes.
5 minutes, so that in all we will have 30 minutes plus minus 10 minutes. Because sometimes the discussion might go beyond that. So do we? Okay, 5 minutes. Okay, now importance of procuring medications from the hospital. All right? Maybe you lead it since you are the one that suggested that. There is no mic, you can just allow so that
distinguished members of high tables, Assalamu alaikum, brothers and sisters in Islam. I brought out this topic because it's very, very important. For every patient coming to this hospital, I want to take in 3 perspectives. The quality of medicine we are giving to our patients as Muslims and as health workers in this hospital. Another thing is the cost of medicine we are giving to our patients. Another thing is time of administration of medicine, that's accessibility of these medicines. These 3 key points are very important for therapeutic success of every patient comes to this hospital. Yes, the quality of medicine. Today in Nigeria, fake drugs, prevalence of fake drugs is too much. Very, very prevalent. And as a pharmacist, my head of department is here, and alhamdulillah, we are not want to boast our morale here. Whatever we do it because of Allah. We know on the day of Qiyamah, God will ask us as a pharmacist. When you work in the hospital, what role do you play as a pharmacist? My head of department ensure that whatever drug comes to this hospital, she herself can take it. And all our members of staff or our family can take it. That's what we call it. Fake drugs are too much. If you go to Sabongeri, because it's cheaper, people direct patients to Sabongeri. I want to advise, we ensure that whatever drug we have here, that may be a small price differential. But when you buy cheap, you buy twice. But when you buy quality drugs, you know that you are giving the right drug to the patient at the right time and at the right quality and at the right cost. Yes, most of the drugs today you see in the market, they are very, very cheap, but they are empty. We have done a lot of statistics, a lot of studies. We discovered that even in this environment, we have seen thermometer and chlorophenical capsules. We've seen people putting ordinary reagent in some drugs, nothing, placebo. And people go there because it's cheap. But we cannot do that here. We ensure that whatever drug we bring to those, they are quality medicines. And also storage. We make sure we store our drugs, like insulins. You see people bringing insulin with empty hands into the hospital. But give to the patient. This cannot work. It must be on cold chain. And we make sure we put our drugs on a cold chain, that when we are giving this drug to patients, up to the point of use, is being what? On cold chain. And accessibility is very, very important. Drugs are available. We have already created satellite pharmacy. My HOD is here. He ensured that every ward in this hospital have pharmacy, so that patients can easily access this medicine. But you see patients going outside, Sabongeri, and along the road, we have recorded a lot of fatal accidents. People going outside to go and buy drugs. This is a key point. Why are we saying this? All patients that come to this hospital must source their drug, must please, we advise them, we should not direct patients to outside to go and buy drugs. There are a lot of hazards. We cannot guarantee the safety for drugs we are buying from outside. We cannot really fight for those drugs. Our drugs, go to any of our centers, you see how we maintain the coldness or the cold chain of most of these drugs. May Allah guide us. This is from IMAN.
Thank you very much. Now, there's a problem. I don't know. Sometimes the patient is prescribed drugs for 1 month, and his money can only buy 2 weeks, and he goes to the pharmacy. The prescription is collected from them. So I don't know whether there's any way they can go around that, because sometimes you ask them, okay, why is your prescription? Okay, when we buy the drug, it's kept in the pharmacy. But he still has 2 weeks before his appointment. So please, maybe you can...
There's always a copy out.
Yeah.
We have a copy out. Why are we not giving prescription out to patients?
Yeah.
Some of them will go out and continue using it without coming back to the hospital to come and refill. So we give them the copy out, which any registered pharmacy is not going to honor. So we give them copy out to come back after 2 weeks, and there's records.
Oh.
We are now on e-pharmacy.
Any other comment on this? We are getting time, so if you yes, comment on this, please. Yeah.
What we've noticed recently, those of us in the nursing services, at times in the ward, the drug is prescribed maybe for a minimum of 5 days or so. And then when patients are asked to go and buy from the pharmacy, by the time they come back, they will not be given for 1 day or 2 days. Come on in an hospital here, so we continue to wonder what to do.
Thank you very much, sir. We discovered that there's method of prescriptions. First, maybe house officer or registrar or senior registrar review the patient. And after the consultant round, they change the prescription. We now discovered that most of the patients coming back returning the drugs. We've now said if you are on the ward, we have UNIDO dispensing system. UNIDO dispensing system will supply 24 hours. That's the story. So as long as you are in the hospital, you can refill from time to time. We have AIE, we have MOPD. In every section of the hospital, we have pharmacy there that you can refill.
All right, so I think 5 minutes has gone on this. Maybe we can continue.
So you can meet us in the pharmacy.
Continue outside the pharmacy. I'm sure I have yes. We can continue after this. The next thing that we said is care for the terminally ill person. So who suggested that so that the person can set the ball rolling? Care for the terminally ill. Well, if the person is, anybody can start a discussion. What is our role in terms of caring for the terminally ill? Yes, doctor.
Assalamu alaikum wa rahmatullah. I'm Habib Musa Muhammad from Aminu Kano Teaching Hospital. I'm a guest here and I'm happy I'm here. And it's a privilege. About terminally ill patients. Last year, the World Medical Assembly was here in Abuja to conduct a regional Congress of African countries. So they will tap our opinions about end-of-life care. It was anchored by the Nigeria Medical Association, and all cadres of doctors were there. The major things that attracted attention were issues surrounding euthanasia and other things. It rekindled my interest in it when someone raised this issue, because I think we need to understand, during that Congress, there were people who were professionals, the doctors, there were there were traditional practitioners, there were even people with no religious affiliations. They were invited, and the summary of it all was that almost everybody agreed that issues like euthanasia are not acceptable, both ethically, morally, professionally, and otherwise, and religiously, of course. Reason for those talks were the world, especially the Western world, were becoming inclined to making it a rule that people would have the right to request to be killed in a hospital, or they will have the right to deny to be treated in a hospital, which could lead to their death. And many things were discussed, of course, and I think these are some of the things we need to also look at when we are treating patients with end-of-life issues. Let's look at the ethics surrounding those topics, and the professionalism, and of course the religious allowances. Thank you very much.
Thank you. So it's okay. Yes. Let's open the speak. Yes.
Well, we know who a terminally ill patient is. That is a patient that there is the tendency of departure in him. And a Muslim who is is having that issue of departure, the possibility, there are expected things that we have to inform the patient that he should know. First, the issue of repentance, tawbah. It is very, very important that he continue to do tawbah as much as possible at that particular time. Number two, he should ensure that the rights of people with him should be taken back to them. This is also important. The right of people with him, whether property or otherwise, should be taken back to them. Then, this is also possible, he should try to write his will. Writing a will is also important. Wasiya, you should also write a will. Then, advising and admonishing the family also is important for him. Because at that particular point, he has an insight of in-between. He has an insight, so his way of advice will be pure and puritan in that particular manner. So those are the few things that should be taken. And a patient relative also that understand Islam should always be by his side.
Thank you very much. And I think you see there are real life situations. Sometimes you have a patient who is extremely sick. Everybody will conclude. Many a times I know, for at least as a trainee undergraduate, sometimes the professor will come and say this patient is going to die, and the patient refuses to die. Somehow, by the will of Allah, you know. And sometimes they will say this person is well, we are discharging the patient tomorrow, and the patient dies. So I think what we need to do as a Muslim, all the patients have their religious affiliations on the card. So we should find a way of looking at it. Because you see, our other people that are saying in the hospital, other religions, they are very organized and active in their crusade. So once you notice somebody is a Muslim and this is the situation, even if somebody is going to get better, our practice should encourage them to observe the religious rites, the daily salat. Because sometimes you see a patient, he will come 1 week, 1 month, he goes to the toilet and come back, that's all. They don't even perform ablution, they don't pray. And occasionally you find some people who are very conscious of religion. They are very sick, they will still tell you, I want to pray. We had one very, very beautiful story. Somebody, I think we all know, in Tunora Hospital, I think it's Sheikh Mora, he died. He was praying. He insisted that they should bring, in Ward 3, I was there. He was praying with his tasbih. He died. He insisted. Each time, throughout the admission, he would insist, I want to pray. It's time to pray. He prays. So you see those exceptional cases, but there are some who are not as, and you know, the sickness also is, people are apprehensive, so anxious. Nobody wants to die anyway. That's the truth. So sometimes that assumption that probably there's going to be death, a lot of people are just off balance. So we need to be encouraging the relatives, encouraging the patient himself, because we know he's a Muslim. Otherwise, we were sitting there, somebody would come and start telling him to convert to Christ. Yes, so is there any other comment on this? Okay. 5 minutes gone? Okay, we'll just take it to the...
Okay, so,
yes.
I just want to share a professional experience on this issue. We are all trained, and many a times when you notice a terminally ill patient, sometimes you could even say, you could even predict how long it will take for him to die. When you find yourself in such a situation, families are also noticing the signs, but they want you to take the decision. They want you to say something. And then you are caught up with Islam, okay, telling you to say shahada to such patients. And then you want to ask them to say that, and you are afraid that when you say so, it will be like you are saying the patient is going to die. I really had that challenge several times. You want them to say shahada to the person who is necessary. And then when you say, once you say so, you are saying the guy is going.
Okay, because you are a doctor.
Thank you.
All conditions are different, but what most of us, and what Iman is planning to do, what Iman is planning to do, inshallah, is to be able to provide learned people who will be going around to remind our brothers who are sick or sisters who are sick about their obligations regarding prayers, to be able to provide prorab for those who are not able to get out and do the wudu, and to remind them. But in the meantime, we are pleading to all of us, whenever you pass through a patient, try to remind him of his obligations to Allah. We want to make it easy. We want to get somebody official, but our salary bill is a bit high now for what we get. So we plan in the next dispensation to be able to provide people to pay them to be able to go around. But in the meantime, it is our responsibility, all of us, to remind patients as much as possible their responsibilities when they are admitted, as well as when you notice that they are about to die. So that becomes standard for all of us. And we are planning to get that. We are also planning to make musalla around, make it easy for people to come out and pray, those who cannot go out to the mosque. So these are some of the things that we want to do.
Yes, the third agenda we said is in line with this, educating patients on religious roles while sick. So that's why we allowed the discussion to continue. I think in a way, we must get close to our patients. That's the most important thing. We must get close to them, because by the time you come in a secular environment like ours, you will come as a health worker, and then you are said to be telling somebody, do this, do that. So people will misread it, and they may raise issues. But if you are close to the person, jokingly, you can, have you prayed today? Have you prayed Zuhr? If you are close, nobody will raise any eyebrow, jokingly. And it's very important for us. And then by the time you draw the patient close to you, they are free to tell you a lot of things. They will tell you a lot of things. And our patient relations also are not helping us at all. Most of them, all they're interested in is that when people come, truckload of them from the village, you must allow them go in to see the patient. It's wrong. Or when they come to clinic, they want to be seen first. Wrong. Okay? So we need to educate the patient relations. They are difficult. The patients are better because somebody who is sick is looking for them to help him. Patient relations are extremely difficult, but we must find a way of getting close and dragging them so that they understand the situation. So I think one way is to draw patients close so that we can jokingly, ask them questions. Have you prayed? Have you done this? Have you done that? I have not seen you. You are well enough. The doctor asked you to stroll around. Why did you go to the Friday service today? Yes, you can actually walk there. In a nice way. I think we can do that. Right. Any other comment on this? Yes, please. Let's care for Amira.
Assalamu alaikum wa rahmatullah. We had an Imam Sisters forum meeting, I think 2 weeks ago or last week, and this is one of the main discussions we had. I think in this particular issue, the role of the nurses is very paramount because they are the ones that are together with the patients mostly in the wards. And I was privileged to be in a hospital in Malaysia. It's an Ibadah-friendly hospital. That means a hospital that they put Ibadah as part of the protocols of hospital care. And I also explained that in that particular hospital, they have a Muslim chaplain, so to say, somebody that is the Ibadah officer. The main role of that person is to go around the patients, remind them that Ibadah, the illness is part of the trial from Allah, discuss with them, do a kind of psychotherapy. And as part of the nursing schedule, the handover notes of the nurses, the nurse will ask, if I'm handing over to him now, I'll tell him, have you reminded this patient to pray? Has she prayed Zuhr? You check, there's a checklist that is ticked. That's the way that hospital is run. Standard hospital with consultants, specialists, gynecologists, urologists, physicians, complete hospital. But they have that Ibadah-friendly way of running the hospital. So it is possible that it can be done. And what we said is that within our own environment, the nurses are closest to the patients. As you are giving patients drugs and you ensure that they can have their drugs either TDS every 8 hours, every 12 hours, put it among your schedule. If you know this patient is a Muslim, please just remind her quietly or remind him quietly, have you done your Zulu prayers? Even if you're on POP and all that, you know that you can rub on it. Some people may have challenges of maybe they don't know that they'll be able to purify themselves before they pray, and how they will purify themselves, whether they should sit on the bed to pray. In as far as they are conscious and they have their senses, they still have their sensorium, they are still supposed to pray, even if it is in the lying down position on the side and so on. So I think the nurses in our hospital have a better role in this particular issue, and I hope we all take it seriously and put it as part of our own schedule, especially to those patients that do not are Muslims. As you are giving them their drugs, you are giving them their injections, you are handing over, please ensure and remind them that they should say their prayers. Then, sorry, since I'm a gynecologist, the labor ward, for women that you have not started seeing blood, maybe you just seem like you are in early labor and so on, we are still supposed to remind them to pray. Except when blood starts coming out and the full labor has been established, they are not supposed to just lie down on the bed. They should be reminded that they should still say their prayers. Assalamu alaikum.
That's if the pain is not unbearable. Okay. Yes.
One very important thing that I'm going to add here is that a good number of times we are very afraid. I've seen this fear in us. In the ICU, I've been privileged 1, 2, 3, 4, 5 times to see the nurses hand over. And when they are doing it, they do it with special prayer, not in the Islamic way, in the other way. Even patient is gasping, they will do it. At least I've witnessed it life. So this is not a matter of them saying. They will do their handover, they will pray in the mighty name of Jesus Christ, do everything, talk, Bible. You come in to come and review patients, they don't answer you, they finish. Of course, Muslims should not do that. That is not, so I'm not saying a Muslim should copy that. But what am I saying is, if these our neighbors could be so confident and proud of what they are doing, why do we always find it, so challenging to stay as Muslims? So you don't need to be rude about it. Saying Salaam Alaikum to your patient. If every time you come and say good morning, you see, it affects. The way you create your relationship, the patient will be happy that there is a Muslim here, or there is a Muslim sister here. And like I always say, Salaam Alaikum is the standard greeting. For those of us that are comparative religion scholars, the Bible is very clear. Jesus never said good morning anywhere. All the verses are clear. He says, peace be unto you. You may memorize one, Luke 24:36. That is how it is everywhere. If it is inshallah, that is the same thing Jesus says everywhere. He said, you don't say you're going to do something except you say inshallah. That is James chapter 5 verse 13 to 17. So if this is established in their own books, even though they have come to become westernized, why should a Muslim? And that's I always laugh when I just see someone, a Muslim shaking to the I've given lectures in most of the South universities and centers. You see this full confidence in them. Even in our own hospital here, Muslims want to pray. You will see Christian nurses telling them they must not pray here. I've seen times where they have to remove their masks. Even senior nurses going around stopping junior nurses from praying salat on the ward. And then you say we just take it and we're so afraid. Innaka mayyitun wa innahum mayyitun. You will die, they will die. That is the end of the story. So we need to be cautious. We don't need to be rude about it, but let us help our brothers and sisters.
Thank you very much. So I think we'll draw the curtain today because of time. The next agenda we said is oxygen therapy. This is the truth actually. Everybody is afraid of oxygen. Once you see a patient on oxygen, it's concluded. Oftentimes in my department, I think we, apart from the surgeons who do it in the theater, medicine wards are the ones that give oxygen all the time. I have always asked questions, do we really give our oxygen correctly? Do we time the oxygen therapy? Because sometimes it's when the person starts gasping, that's when we give oxygen. That's not the time to give oxygen.
When somebody is gasping, how many times you just see the oxygen open very high speed and all this, and it's just going round. Then you gasp once in maybe 30 seconds, and it takes more. So I think the timing that is wrong. So we need to educate ourselves. Even some of us, hospital staff, when we see oxygen, we also come and not help. And as a hospital worker, when somebody is very sick, maybe fracture, he has broken his leg, and then you come, they say your hospital is like a child and his father. They are traveling, and they see snake, and the father begins to run. Well, what will the child do? You are the hospital, we are the hospital staff. So by the time you show that you are already weak, all the other people, including the patient, they will be weaker than you. So a hospital staff is supposed to be strong. Whatever it is, even if you know that the person may not make it, because of course it's in the hands of Allah, we have said it before. Somebody that you've written up is going to die, may refuse to die, God will leave him to teach you a lesson that you don't have the powers to say somebody will die. So just be strong and continue. When his time is up, he will go. If his time is not up, if you like, don't treat him, he will not go. Okay? So I think it's for us to understand oxygen has its own indications, and when somebody is giving oxygen, there are ways oxygen is delivered. The anesthesia people will teach us if we want, the ones that are versed with that, you know. But the patients, we need to teach the patients' relations and the patients themselves. Because some of them will vehemently tell you, remove that thing, we don't want it. Please, so let's take comment. Because we are supposed to be the ones educating the patient relations about oxygen. Comment?
Yes. There's, okay, just give me, behind you.
This is a serious issue. And it has become an omen, especially up when you move from Tudunwada to city. The interpretation of bringing somebody to Shika is that he is going to be mocked up. No, that's just the issue. And one of the basic signs of about to go is to come and see that thing on his face. The moment that marks there to Shikena, that man told Allah de. So this particular issue, it doesn't only stop at us understanding, it also goes back to we in the community and whatever, how we call, and informing these brothers and sisters, especially the patient relative. As Professor said, patient most at times is obedient because he wants to get well. But the patient relative, they are even when patient refuses something, he must has been told by his patient relative to refuse, one way or the other. So basically, it is important the patient relative also lead that, and part of what we should do one way or the other when we interact with them is even jokingly to talk to them about this, that even someone who is very well, there could be reason why he will have this particular issue, and we get away with it. Allah.
Okay. Take it there. And then 2, 3, go.
Assalamu alaikum wa rahmatullah. The last speaker, I want to contribute something to what he said. See, the issue of Shika actually, I think, is beyond this forum. I think this body needs to go outside this forum to educate our society, our environment around Shika. I can remember last year, one patient came to Tudunwada Hospital for X-ray. A female just came out. I met her, she was telling patients that I was in Shika. And before I get there, somebody told me that once they talk to me, I shouldn't listen to them. Once I answer, that's the end. And unfortunately for me, I was going around and I was meeting somebody in black. That's one of our fire service people. And the man saw me 3 times and he asked me, Hajia, what are you looking for? I said, she ran away and they asked her to go to Chilo for X-ray. So I called her. I was the one that did X-ray for her. I said, Hajia, I heard you tell me somebody were in Shika. Remain small that you were killed. She said, yes. One man in black, he told me that once they said anything to me, I should not answer them. Because that Shika. Then after the x-ray, I now asked her, Angela, do you know that I am a staff of Shika? She said, how look at this and said, are you serious? I said, yes. What do you have in mind about Shika? She said, you were told that anybody that goes to Shika, his own has ended. And that is the impression everywhere. Not knowing that most of our patients, they don't come to Shika at early stage. They will go to private hospitals, spend their money, cases deteriorated, when they cannot manage the patient, then they will not refer them to Shika. And at the end of the day, the patient will die in Shika, and they tell them that, you see, we told you. I think we need to do more about that, more than this forum. We have started one program in NT Zaria called Patient in the Hospital. I would advise this forum to please do same in the radio and NTA so that our people will be educated that we are not here to kill people. We are trained to save life. That is what I told our woman. I said in hospital Shika, we have Muslims organizations, we have Christian organizations. How can we see people killing people and we will allow them without saying anything? And you cannot get promoted until when you save lives a lot. Your hard work will make you to be promoted. So I think it's very important. Secondly, we have issue of this gas issue. Of course, as Muslims, we need to recite, come not to shahad with the patient. But there is issue in the world. Once a patient has oxygen on his face, the relation will want to come closer to him so that they will be reciting Kalmatu Shahada to him. And they start to ask relatives to go out. Nobody should stay with him. And unfortunately, maybe for the patient, the person staying with him is not a Muslim. I think we need to address that issue too as well. Thank you very much. Assalamu alaikum wa rahmatullah.
Assalamu alaikum wa rahmatullah. Me, I would like to start from the basic, from the initial stage, even before it gets to administration of the oxygen to the patient. I stand to be corrected if I'm wrong. There's this thing that really bites my mind. That I don't really know how to change it. So to say, maybe I should just use this forum if our fathers can actually help us to intervene. In this oxygen administration of a thing, is it when it's available that you say, okay, let me administer? There's this thing of chronic diseases. If your patients need oxygen, before, the way I used to know it is the oxygen is cylinder is usually filled and kept. If patient is gasping or something, or you notice the SpO2 is beyond the normal range, then you can educate the patient and you start administering if they agree to it. But now you have to, if you notice the patient is gasping or something, you have to write for the patient to go and pay before the oxygen can go and be filled and bring it. In fact, there was a day this thing happened. Honestly, I feel like I just feel like, who will I even see to transfer my anger on? Because they went to fill this before you even try to convince the patient relative that, okay, this thing is needed. They take the SpO2 is below, so this patient at this point needs oxygen administration. It takes you some minutes, in fact, maybe 10, 20, 30 before you be able to convince them. Now you now say, okay, go and pay. You have to go and pay before. If they will now go and join that queue, they will go and pay. Then before you now get your attendant to go and fill it and bring. At following all this protocol, before that attendant returned, he was just returning. I think it was just by the door and this patient passed. The next thing the patient will tell you, this patient is going to die. Who can you do here? They will now transfer that aggression on you. Please, if this protocol can be a little bit loosened, ward, I think that is too tight. Is if they can ease that process of patient, someone going to fill oxygen before they come. Then my second point is as health worker, both the nurses, attendants, everybody, even the doctor, when a patient needs oxygen and you met a colleague of yours is trying to convince this patient, don't just walk away. Try and be part of that, because they say two heads is better than one, or so I don't know if I say it correctly. So if you assist this person, if both of you convince this person to take this therapy, it works. But don't just say, oh, well, that person is there with the patient already, at least you should be able to handle. Yes, whether she can handle or he can handle. But if you two add your own, no one can tell. It may be your own what may convince the person. This I think we really need to acquire the knowledge in order to be able to pass it to those that we need. Thank you, someone.
All right. Please, let's make our comments very brief because we are already eating into the DLS time. Like we said, somebody wants to comment briefly.
Thank you, sir. Actually, most have been said that I wanted to say. The issue of oxygen, I wanted to look at it in the terms of availability, affordability, and acceptability. She has talked about affordability and availability. And these days it's quite difficult to access oxygen. But thank God we have oxygen concentrators, so we can be using them. I think they are free in most of our wards. So in the absence of the 100% oxygen we collect, we can use concentrators. The issue of acceptability. I'm very happy that the chairman talked about timing. Timing is very important. If you come to our unit pediatrics, oxygen is not an issue. People are more scared of NG2 than oxygen because they see that the patient gets oxygen and they go home. So issue of taking it is really not so. Timing it, in other words, will be very important. Also, we should take time to explain to patients. We usually believe that we don't have time, but we should have time to explain to patients the importance of these things. And I think they will accept. Thank you very much.
Very brief comment from Amir.
Assalamu alaikum. I think this oxygen thing is very important for us to know how it is administered or why it is administered. There was a lecture I gave on oxygen therapy and I titled it, I added as subtitle, Angel of Death or Savior. Are you using it to when the patient is about to die only, or you use it to save the patient from dying? And most of us, unfortunately, wait until the patient is very ill without knowing even if that oxygen is indicated or useful, and you administer. That is what has brought the concept in the minds of people that oxygen, once they put oxygen on you, you are just gone, that's all. And that is probably, we have to correct it from ourselves within the health care providers first before we go to the relatives. And so you give it when it is necessary. I can give a lecture when necessary about oxygen therapy, and I think it's good for the hospital. But it is very badly abused. When somebody has blood pressure of 60 over 0, you don't know what it is, and you're putting oxygen mask on that patient. It's not going to help get anything across to the patient. So we have to know what, when, and how to administer it. And we can arrange a lecture anytime about that. Thank you very much.
Sure. Thank you very much. You know, oxygen is a drug, and our special guest of honor is the chief of drugs in ABU. So she wants to talk about it.
Assalamu alaikum. What I just want to add is whether we're looking at the possibility of getting emergency supplies for emergency cases. Like we have emergency supply of drugs for emergency cases in the wards. I think we should think of getting some emergency oxygen supplies. And the best people that can propose it are the nursing services. So I want to suggest to our nurses to discuss with their HOD Just like they made a good proposal for emergency supply of drugs, they should look at also possibility of making emergency arrangement for supply of some cylinders for emergency cases. I know that they can do it.
Thank you very much. I think we have very little time left, and the last two themes are traditional and orthodox medicine. We'll just take that for 2 minutes. The doctor that suggested that will give us a brief on it, and then the self-help, care for self. So orthodox medicine and traditional medicine. Unfortunately, there is very little anybody can do about that. It has a very large, very big area, beliefs, practices, and all this. So please, doctor.
What I noticed, especially if you are listening to radio stations here in the area, most of the traditional medicine sellers, they usually recite verses of glorious Quran and they begin to read some hadith of the Prophet ﷺ, and usually attach to as if it is related to Islam. And when you look deeper into the procurement of their medicine and how they do their medicine, you discover that Islam is separate and the traditional medicine is separate and the modern medicine is separate. So it's important for a healthcare worker to actually read most of the books that's in the major books of religion that talks about Iqbal Islam, especially if somebody has a privilege to read the book written by the scholars concerning the prophetic medicine, so that as a healthcare worker, that's a modern healthcare worker and Muslim, you should be able to separate. This is pure Islamic medicine and this is traditional medicine and the other one is the orthodox medicine. It's important because they usually read verses of glorious Quran and attach it as if it is Islamic, and many people tend to believe in them. So it's important to know the dividing line in between the three so that we can advise patients accordingly. Thank you.
Thank you very much. You know, it is a very large topic, like I said, and you know, they will come and start to tell you that the fully die in the hour for every sickness there is medicine, one any. The parakeet, these are the ugly big deal. The ones they eat with the religion, so there is little you can do. The big problem we have as health workers is that the government has regulated medical practice of the modern way, but there is no regulation for the alternative medicine. And that is why they can get access to radio and other things and do. So it's very difficult, it involves policy, so many other things. The most important factor that encourages that is the patient's belief and cultural practices. If you tell somebody now, don't go and take this, he will tell you that you don't know anything. If not English, what else do you know? In our wards, in our medical wards, they smuggle traditional medicine to give to stroke patients. At the point, in Tudunwara Hospital, we know anybody coming with stroke, 80% of them that die, they die from aspiration of traditional medications. So they do it. Even here they do it. Maybe we don't see it, but they bring traditional medicine even here. So it's a very large area and it's enshrined in the beliefs and practice of people. It's very difficult. But like you said, it's important for us to educate people. But there's an extent to what you can go to, how you can go in educating people about traditional medicines. Unfortunately, government refused to regulate it. In other areas, there are complementary medicine boards and other things in other countries. But Nigeria, they are free. Once you can recite some Arabic text, it doesn't matter to be Quran. They just recite Arabic, that's all. And everybody will follow them. Even the Christian, our Christian colleagues, they write Bible in Arabic and they give people and they say they will start praying with it. So that's the problem. That's how bad the thing is. So the last thing, sorry, we'll have to cut this because we are short of time. The last thing is care for self. I said this and I'll just briefly talk about it in 1 minute. And, pardon? Okay, you will talk about that. You see, there was a time, I think the nurses' day in this hospital, and they said they are going to do blood pressure
measurement-free, level 1, around the accounts office. And I was just passing by, and anybody they take the blood pressure, they write it. Normal, they write in blue or black, then abnormal in red. So I just said, let me see the records. And half of the page is red. And this is we and you. We in the hospital that are running around, jumping. And people have red blood pressure readings, very high. It's very important for us to take care of our own selves first before you can go and talk to another person. Once you are 40 years, once you reach 40 years, all the troubles will start coming. Everything, diabetes, hypertension, cholesterol, everything will come. So I think it's important for us to check. Nobody will stop you from dying if you start for you to die. Nobody will hasten to kill you if that has not come. But you see, quality of life. You need to live a qualitative life where you can be able to pray, you can be able to go and visit your relation and get reward, you can be able to go to work and treat patients and get better. Not to live a life of a stroke, you cannot even talk, to go to the toilet, they must escort you and stand and have you finished? It's very distressing. You are inside the toilet, somebody asks you whether you are okay, are you toilet, I want to clean. You know, so let us avoid that. It's very, very important. So that's somebody what I want to say. Finally, okay, Hajab, if you want to say something before I conclude. Sorry. Yeah.
Still on traditional medicine. Yeah, it's true. I just wanted to add that we should also remember that patient counseling is our responsibility, all of us. Anybody that is working in the hospital has some part of responsibility in patient counseling. Whenever you come in contact with a patient, you are supposed to counsel. And this counseling, the best way you can achieve your aim is when you use some motivational factors. The most important motivation in counseling is if you are able to tell the patient what he stands to gain from whatever you want him to do or what he stands to lose. That means how that thing is going to affect him, affect his life or affect his health. You stand better chance of achieving your aim. So in this issue of traditional medicine, the important thing is for us to be able to tell patients the disadvantages. Whether it's Islamic, traditional, or whatever you call it, if you try to compare it with Orthodox medicine in terms of advantages, you will have some reasons to give the patient, what I do is I don't tell patients not to take, but I try to show them the importance of using, if you come to the hospital, importance of using your Orthodox medicine. If you say because you are using traditional, somebody told you that you cannot combine it with Orthodox, you tell him what he stands to lose and how it can affect him. Because by especially bringing the disadvantages of some of this traditional medicine, issue of the lack of dosing and so on, you try and pinpoint the patient and even try to ask him, can you tell me how many people have benefited from this treatment? Many of them will not be able to tell you, but some might be able to give you some examples. But by the time you analyze those examples to them, they will realize that they are not directly related to the traditional medicine. Once they are able to do that, you'll be able to convince them to use. If they want to use their traditional medicine, just allow them. But in cases where there can be interaction, just try and tell them how to use it without actually affecting their Orthodox medicine. But most importantly, tell them that these things are more advantageous. Show them the advantages of the Orthodox over the traditional. And I'm sure you'll be able to convince most of them to stop the traditional medicine.
Well, I think we don't have time. I agree. We can continue that. I would want to suggest to Iman, the director of programs, that Iman blog that we have, some of these discussions should better, we can be doing that on a daily basis. I suggest that we can create time for such on the blog instead of some stories that may not be relevant to all of us. We can discuss issues of common interest like this discussion. So I think the Imam blog will help us to solve a lot of this problem and educate ourselves on that. So I'm suggesting strongly that we do that. Now, the issue of traditional medicine, I hope Ajabiki is not telling us to engage the traditional medicine people, because I tell you a small story. When HIV/AIDS came, there was a time the Ministry of Health and some NAFDAC called traditional medicine people in Kaduna, and I was invited also. that they should come, they want to educate them. So the people thought they are coming to harass them. So as the chairman of the occasion stood up, I think from NAFDA or from somewhere, was giving talk about traditional medicine, it may not be good to have them be started conversing. So they say one of them has shot her. So everybody scattered. So you see, I think we need to be careful. And our interaction, our dealing will be mainly with the patients. Let us deal with the patients and educate them. And you know, whether we like it or not, these people, the patient will tell us traditional medicine works. Like doctors said, people look what they tell you they have read the prophetic medicine. He said everything is allowed for diabetic to take honey. But if people look what you just draw their attention. How many times? How was it prescribed? You just put your finger and lick 3 times, once, 3 times, 7 times, 11 times. But our people will carry spoon because people never say you can use honey. So it's the way they are using it. So I believe it's, like I said, it's a large topic. We will not be able to do justice to it here. Unfortunately, we are limited as an Ummah here by the fact that we don't have control of policy and we don't have the powers to stop anybody. But I think we can educate our patients as much as we can in terms of the orthodox and the side effect that would happen. You know, a lot of them will damage organs. Now, I think we've come to the end of the open discussion, and I would want to thank the organizers for giving me the opportunity to chair this very lively discussion. The next item is citation of our CPR instructors. Then I'll hand over to the program organizers to continue from there. Thank you so much.
Thank you so much. Jazakumullah khairan. May Almighty Allah continue to increase your knowledge, protect you and guide you. And to everybody present, thank you so much. I think we've come to an end of the first chapter of this program, which is the discussion. So we are moving to the CPR proper. But before we continue, we are going to have the citation of the instructors. I'll call on Dr. Babatu Abdul Rashid to come and read for the citation of the chief instructors for today's program.
My parents, sisters and brothers in Islam, Assalamu alaikum wa rahmatullahi wa barakatuh. I will be giving a brief biography of our instructors, our brother in Islam, our uncle, our father and our tutor. I'll start with Madam Sani Adamu. Could you please stand up for you? Thank you. Madam Sani Adamu, of course, he was born a Muslim. He is currently a registered nurse, a DPA, a CCN, a chief nursing officer, and also a fellow with the West African College of Nursing, working with the ICU, Amin Kano Teaching Hospital. He has gone to a greater height to become a provider and a core instructor of the BLS and ACLS, working in collaboration with the American Heart Association, Liceron, and United Doctors of Riyadh, Kingdom of Saudi Arabia. It's a takbir for him, please. I'll go on to the chief instructor, who is also our brother, uncle, father, and tutor, in person of Dr. Habib Musa Muhammad. Could you please come forward, sir? Oh, okay. Of course, he's a Muslim brother, born as a Muslim. He completed his study with the Federal Crafts School in 1989, progressed to have an OND with the Medical Engineering, SOT Kano in 1992. Also progressed to acquire his MBBS certificate from UNIMED in 2000 and a DA in West African College of Surgeons in 2005. And He is now a fellow with the West African College of Surgeons, which was acquired since 2009. He's a senior consultant with the anesthetic department in Aminu Kano Teaching Hospital, a provider and instructor for BLS, ACLS, and PFCCS in collaboration with the American Heart Association and United Doctors of Liceron. He's a coordinator and lead instructor with Aminu Kano Teaching Hospital life support training programs. He has gone a greater heights to become a staff champion and instructor with the Pain-Free Hospital Initiative, also with the American Cancer Society. He's an immediate past chairman of the AKTH Pharmacovigilance and Palliative Care Committees. He's currently a national chairman with the Rapid Response Initiative of Iman, Islamic Medical Association of Nigeria. Our fellow brother, Dr. Habib Musa Muhammad, is the state chairman of Iman Kano. He's an ex-official of Iman AKTH. Subhanallah, he's a chairman of Iman AKTH and Capital Projects. He's a patron to the AMHS BUK, a member of Board of Trustees, Baure Da'awa Foundation, Clinic and Maternity. He's presently a member of the following: Iman, NMA, MDCAN, GHI, SSPN, NSA, and IASP. Of course, whatever you do, you don't forget about your family. He's a family man. He has a mother, married to 2 lovely wives, and has 7 sweet children, with several siblings and dependents. A takbir once again. Thank you very much, sir. As you have come to contribute to the Ummah, may Allah reward you both, and may Allah make it easy and make it useful. Whatever you're going to impact to us should be useful to us and to be as a part of Jannah. Thank you. Sir, please come on.
Assalamu alaikum wa rahmatullahi once again. The full BLS course is 8 hours. I have discussed with the program. So what we aim and intend to do now is give you the basis of the basics, and then whatever remains, we will find time and arrange how to do the full certification. The American Heart Certification is usually provided having completed the course and having completed a post-test and other requirements. So let's quickly talk about BLS, which is the subject for discussion, and we will take some practical sessions. That's why you may see us with mannequins in front of us. It's going to be a video teaching. Simply look at what the video is doing and do the same, and we will be there to take you through. But before we start, let me give us some basis of why we do CPR in Islam. You see, the scholars in Islam said, "Inna min takrim al-mawta dafnuhu ala al-waqt illa an yakuna fuj'atan," that it is part of respect for the dead to be buried early, except the death is sudden. Because those days,
there was no knowledge of CPR. So they made it a requirement that people that suddenly collapse and die, please wait, so that you don't just go ahead and bury someone alive. And this has come to be one of the dilemmas we have in our healthcare settings, especially with brought-in death, as we shall discuss when we go through the course. Of course, Allah SWT said if you give life to one person, it will be as if you have given life to the whole mankind. And if you kill one person by omission or commission, it will be as if you have killed the whole mankind. And this is what has been driving me in the last 14 years to be teaching CPR, so that more and more people will benefit from the skill, and more healthcare providers will be more confident to take care of their patients. So like I said, it's going to be a video. Let's simply go through it.
Cardiovascular diseases claim more lives than all forms of cancer combined.
Early recognition and CPR are crucial for survival from cardiac arrest.
High-quality CPR saves more lives.
American Heart Association. Products are shown for demonstration purposes only. The American Heart Association does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use recommended personal protective equipment, such as gloves.
This is the latest American Heart Association guideline for CPR BLS. It was reviewed in 2015, released in February 2015, and it is therefore the correct for American Heart. And the guidelines are usually reviewed every 5 years. So it has been reviewed 2010, 2019, 2005, 1995, like that. And you will find a lot of changes and improvement in the quality of CPR provided, depending on researches that were conducted and many other things that are meant to improve care delivery.
There are moments in life we wish we could freeze in time. We live them. We live for them. They are intimately personal. They're glad to share. What is life if we cannot experience these moments of joy, wonder, and happiness? We want people to experience more of life's precious moments. To do that, we must be healthy in heart and mind. For the heart is where life's moments are felt most, and the mind is where these moments become memories and are relived again and again. It's why we made Better Heart and Brain Health our mission, and together we've made an extraordinary impact. Healthier adults, more active children, stronger survivors. But we are just beginning. Until there's a world free of heart disease and stroke, we'll be there, making a healthier, longer life possible for everyone. You may ask, why do we do what we do? The answer is simple. Because we are the American Heart Association and the American Stroke Association. And life is why.
unites matrimony between the American Heart Association and the American Stroke Association. It emphasizes the fact that there are two vital organs in our body, the brain and the heart. If I may ask, which one is higher than the other? Yes? The heart, why? The brain, why?
Yes, we are healthcare professionals. Why is the heart better, or why is the brain better? I personally have one answer for it. إن في الجسد مضغة إذا صلحت صلح الجسد كله وإذا فسدت فسد الجسد كله. So usually the heart will take lead. And that as Muslims, and that is what we believe, because it is said from a mouth that will never, has never, and will never say things that are wrong. And it was only after about 1400 years that some scientists realized that that was true, because they came about the concept of ANP and BNP, atrial natriuretic peptide and brain natriuretic peptide. These two proteins are produced by the heart, just close, very juxta to the sinoatrial node at the entrance of venous blood into the heart. And before it reaches the brain, it would have become well admixtured, and most of the effect is on the brain, specifically the limbic system, and that is why it is termed brain natriuretic peptide, because most of the concentration of that protein is found in the brain. And therefore, these two organs are termed by scientists the vital organs. Why? Because they have the shortest window. Window means from the onset of symptoms of a disease to the time an organ may develop a damage, permanent or reversible damage. That's the window. And during sudden cardiac arrests, the heart stops pumping blood and circulation ceases. And the victim will therefore only survive on his own oxygen reserve. We reserve our oxygens in our lungs, dissolved in our plasma, and mostly carried on hemoglobin. Total of everything is only 1 liter. But at basal metabolism, every minute we are using up 250 mils of oxygen. So without fresh supply, how long would it take me to exhaust my reserve? 4 minutes. Meaning, in the event of cardiac arrest, if within 4 minutes you did not do anything to the victim, he will become dead. And that's why these organs are termed vital organs, because within 4 minutes of no fresh supply, they will suffer permanent damages. And permanent brain damage sometimes will be called brain death, and permanent damage to the myocardium will be called clinical death, because that's the event during massive myocardial infarctions when a significant amount of the myocardium is damaged beyond reversal. So that's why the two associations came together to make sure that this type of trainings and skill acquisition are there. In fact, it is now a world standard that in a hospital setup you don't start practicing until you are certified. And this is the good news we received last year in my center when it has been adopted, that all newly employed must be trained in BLS. And then as you are approaching your promotion, or if you are in residency training, as you are getting from one stage to the other, you have to also be trained in ACLS. And so, many a times in our work, we don't get praised. Mostly, it is those things we do wrong that will usually go into the air, like the issue of taking patients somewhere to be killed in courts. It is not for you to be waiting for your patients to praise you or to thank you. Simply put in your best and see that you are actually doing what is required of you professionally, ethically, morally, and religiously. And therefore, that will give you a good mindset and make you less vulnerable to other things that will make you become old early. So let's go through the course.
I would say the first time I performed CPR, I felt frightened.
Confused.
Scared. It was surreal. I wasn't sure if it was good enough, and if the patient didn't survive, I wasn't certain, was it me?
And suddenly, he stopped talking to me. I was getting ready to take blood pressure, and he just stopped, like mid-sentence.
I think 3 years older than me, and he was probably on the front steps of a coffee shop.
The medics called, and they were bringing in a guy who was having an acute MI.
It sometimes can be a scary situation. Relax. The training and skills are there for a reason. You know what to do.
It's such a practice thing. Everybody's taking CPR. You've done it so many times.
It was more like in the moment and I knew what to do. So I felt confident in my skills.
There's always that moment where you've got to step over your own shadow to let the training and the fundamentals, which you know is important, come through.
You never know when you're going to need to use it. And when you do, you don't want to have to stop and think about it.
Things are always changing. American Heart Association helps you stay on top of that.
The American Heart Association training is really focused on providing you with the tools that are needed for resuscitation.
So learn the right, listen to what the instructor's saying, and do it well. And then be prepared that it's not going to be like that.
We always need to perform. We always need to do what we're called upon to do, no matter what the situation is.
We coded him. We ran the code. We did CPR. We shocked him, and we got him back.
And very quickly went back into a normal rhythm.
It's the look on his face and talking to his family that I really remember.
It was a good day.
Everybody knew their role, high quality CPR. A couple of weeks later, the gentleman walked into the firehouse and shook my hand and said thank you.
When you realize that this guy was completely, out and his heart wasn't beating, and you just brought him back. That is an amazing feeling.
We would have seen those comments from different angles. Firemen, nurses, doctors, okay, paramedics, telling us that CPR is not a one-man show. It's a teamwork. And if you don't operate as a team where you work, usually it will not be successful. Because you need to identify your roles, your skills, what each of you can do at what time, and allow that person to provide that care at the material time you are taking care of the patient. And that is what will ensure that your patients get your best.
Those are just a few stories of providers who know the importance of what you're about to learn. Basic life support, or BLS.
On any given day and at any time, you can encounter a victim of cardiac arrest, because about every 90 seconds, a person dies of sudden cardiac arrest. And with the training you receive today, your actions can give the victim the best chance to survive.
Sudden cardiac arrest occurs without warning or within just a few minutes after symptoms appear. The term heart attack is often mistakenly used to describe cardiac arrest. Although a heart attack may cause cardiac arrest and sudden death, the terms don't mean the same thing. Cardiac arrest occurs in both men and women, but for demonstration purposes in this course, we will perform CPR on adult male victims.
come out, I don't feel so great.
Well, that's why we're here. Just make sure you tell Dr. Morgan that. Dad. Oh, please, can someone help me? My dad. He's just lying out there.
Hey, Carolyn, we have an emergency out here. I'll find Ben and help you.
My dad's out here.
Wait, stop! Can you help me? Just stop in the traffic from passing us, okay? Please.
Hold on, just hang on. Something's wrong. He fainted.
What's his name?
Bill.
Bill? Hello? Are you okay? Go inside, have him call 911, ask Audrey in the front desk for the AED, and bring it back with you.
What
the AED, show me what it is. 1, 2, 3, 4, 5, 6, 7, 8.
Call 911.
I got it. What's your dad's age?
49.
He's 49.
And she wants the AED.
She asked for the AED, so it may be cardiac arrest. Yeah.
17, 18, 19, 20. 1, 2, 3, 4, 5, 26, 27, 28, 29, 30. Can you hand me the pocket mask? 2, 4, 5. I'm giving your dad CPR. We'll use the AED in a minute. Audrey can answer any questions you might have. Is there a razor there?
Yeah, I'll send this chest and come CPR.
Apply as victim's bare chest.
1, 2, 3, 4, 5, 6, 7, 8, 9, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. 1, 2.
He's receiving CPR. Hey, did you come in right after your dad collapsed?
Yeah, right away.
Okay, so it's been maybe 2 minutes. Okay. They should be here in a minute or 2. Feel free to ask me any questions, okay?
Okay.
Line is passed.
Can you be ready to take over confessions?
Sure.
Analyzing rhythm. Do not touch the victim.
Stop. Clear patient.
Stop. Advise. Target. Do not touch victim.
Okay, clear.
Can you call for the ambulance and drive it over here?
Stop delivered.
Stop delivered. Revealing test confirmed.
You need to keep on faster. You need to count out loud 30.
13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
30 more.
How many shock cycles have you been through?
Just delivered 1 shot. We started CPR pretty quickly.
I'm ready to get breaths.
16, 17, 18, 19, 20, 21, 22, 23, 4, 5, 6, 7, 8, 9, 30. 10.
Hold on, stop. You just moved. He has an organized rhythm. He has a pulse, and he's breathing now. Let's go to the transport.
Come on. I'll get somebody to take you to the hospital.
That was interesting, isn't it? Yes, and we wish we were there. That is called integrated healthcare system. Okay? An integrated healthcare system starts with the public, the boy. This boy brought his father to the hospital, a private hospital, and the father collapsed at the car park, and that was what happened. Let us compare that to our setting. What would have happened? First question is something useful. That boy realized that his father needed help. needed help within a short time, and he rushed into the clinic and shouted, "My father is out there, lying down." And the first person he met was the office assistant, Audrey. In my setting, Audrey would say, "Okay, I'm coming." That, if you are lucky, Audrey was actually writing something tangible. Otherwise, he's looking at soccer. "Yes, Barcelona." "I'm coming." "Okay." And that's how he's going to spend the whole time. I used to say something that happened in my place. There was a time we were using only 2 gates for the hospital, and one gate was entrance, the other was exit, strictly, especially as far as the security personnel are concerned. And one day I was exiting the exit gate, and I saw this taxi driver trying to come in through the same gate, and they stopped him. Blood was dripping from his taxi because he was carrying a pregnant woman, telling you how much blood she has lost already inside that car. And the security was saying, "This is exit, go round." Going round means going through Gadaladu, for those of you that know Ghana. And that time it was under construction. So you can spend the next 2 hours in that corner before you come round the entrance gate. Sometimes you come to the emergency and the first person you see is the triad, and you say, "Go and open file," without even assessing what is wrong with it. Go and open file. The person to provide file will say, "Go and get the receipt." The person to give the receipt has gone to ease himself with fault. So before you know it, file is open. Doctor will see and certify death, and usually will certify death based on 3 cardinal signs. We will discuss them later. But Audrey got up to her feet, called one of the nurses to help with the emergency outside, started recruiting other people in the hospital to come out to the emergency, and then herself called 911. What is our code in Nigeria? Who said we don't have? We have since 2016. Yes, we have, and it is 112. Ah, that's the question. Someone said, "Is it working?" Try it on your phone. It has been approved. The bill has passed through all the different stages operating by the National Assembly, and they have approved it. But one thing that did not work. The service providers don't want to give free service because they have already exhausted all the profits on some people. That's not my problem. I am only teaching life support. The nurse that was first called was running. In our setting, if you are called as a house officer, that is the time to start working as if you were once paralyzed. Because we don't believe in what we are going to discuss next, the chains of survival. And we will discuss the details of the chains of survival, including early access. That you need to give your patients the best and the prompt care they require before they deteriorate. Remember, I mentioned it's a 4-minute window, so everything has got to be done within 4 minutes. We are discussing integrated healthcare system. So we have talked about the boy, the community. We have talked about the healthcare setup from the office assistant. Now that nurse came out, and there was danger because there was an oncoming traffic. Oncoming traffic is a danger, especially in out-of-hospital settings for cardiac arrest. And she stopped the driver and begged her to take care of other traffics, and the driver obliged. How many times would you be stopped for emergency and you would do that? Sometimes you will just, the chairman said he will just negotiate and That is even if your car can negotiate, because other cars will just run over the person stopping them. And sometimes this is what happens when ambulances are carrying sick people or are going to carry sick people to the hospital. You will see people in the community not knowing the importance of ambulance, blocking the ambulance or following the tail of the ambulance. And it once happened to me. I was dispatching a patient from a private setup to my center in our ambulance, and that ambulance was damaged because someone wanted to use our siren to pave way for himself. Yeah, that's what we do. And that's why many a times we don't even get our patients to the hospitals on time. And these things would have solved that problem we are complaining about, of saying that people only come here to die. No, it's because most of us are also guilty of these problems. For example, how many times do we teach our children what to do when there are accidents at home? Say, fire accident. How many of us do drills at home? I do. How many of us even have fire extinguishers at home? We usually don't keep, isn't it? Because we are not emergency conscious. And that's why everything that I will say, even in this context, that was a wrong interpretation of the verse itself, okay? And we need to be proactive, we need to be prepared. That's why sometimes you hear after a fire accident in a house, they will say 6 children died. Because when the fire started, the oldest one opened wardrobe and entered. The one following entered under the bed. It could be as simple as telling them just run out and shout. That could have saved all of them. Just run out and start shouting fire. But we usually don't do that, and we don't keep things that would save us. And this is a wrong tawheed, a very wrong tawheed. It's because gaskiya mun rena Allah sometimes, so we don't say whatever happens, it is Allah, because you think Allah will be causing you calamities. No, He will not be causing you calamities. It's just that we don't want to make our systems look like this integrated system. Everybody feels he will do it on his own, and that is another wrong thing. Let's discuss the chance of survival.
First, let's talk about the adult chain of survival. There are 5 links in the chain. It starts with immediate recognition of cardiac arrest and activation of the emergency response system. Then it moves to early cardiopulmonary resuscitation, or CPR, with an emphasis on chest compressions. After that, rapid defibrillation is used. The next link in the chain is effective advanced life support that leads finally to integrated post-cardiac arrest care.
And this chain is really a useful method.
CPR in a safe environment. You don't want to perform CPR where you or the victim is not safe. For example, if you had a shout, fire, fire in the neighborhood, and you were able to get access into the house and someone is collapsed, please take him out before you start anything. Don't start CPR in the fire scene. Okay? If you find people on the road after a road traffic accident, don't start CPR on the center of the road. Move them to the side. Of course, moving the victim does not mean putting him into the car and carrying him to Shika. That's not the meaning, because the time you will take to do that is, but make sure you move the victim to a safe place where you and him will be safe while CPR is going on. Assessment means you want to check whether the victim is in cardiac arrest and actually requires CPR. And this is a normal art of medicine. In medical practice, we want to make diagnosis before we treat. So you want to assess the victim to confirm, is he in cardiac arrest or not? And usually you are going to be checking for 3 cardinal signs. These are the signs of cardiac arrest. And whenever they are there, the victim is in cardiac arrest, start CPR. As we shall learn now, you will be able to check the 3 within only 10 seconds. They include unconsciousness. If a victim collapses and is not responding, it means he has established the first cardinal sign. And the easiest way to assess that is to tap and shout, "Hey, hey, are you okay?" While you do this, you are actually stimulating the victim with 2 types of stimuli: tactile stimulus and vocal stimulus. "Hey, hey, are you okay?" You are doing the 2 together. If the victim is conscious, meaning he's responsive, the least he would do is open his eyes and look at you. And if that does not happen, it means he is not conscious. You have established the first sign of cardiac arrest. You want to shout for help as soon as you have anybody unconscious, because you don't want to start treating unconscious patients alone, lest you get tired or exhausted early and you cannot continue. So you need to shout for help. As people arrive to help you, before people arrive to help you, would have checked for the other 2 signs of cardiac arrest. Check to see if the victim is breathing. If he's breathing, you will see the chest rising and falling. Be careful. Most victims of cardiac arrest, especially within the first few seconds of cardiac arrest, may be gasping. And I was happy that the chairman told us gasping patients are not treated with oxygen. And that's very correct. Because when patients gasp, the air they take in does not even pass the anatomical dead space. So there will be no gaseous exchange for whatever they are taking in. That, on top of the time they take before the next gasp, will only make them worse. And that's why gasping patients need to be treated with rescue breathing. That we may discuss later when we are discussing how to use the Bagman system. So, some victims of cardiac arrest may gasp, and when they gasp, they are not actually normally breathing. And if you find that someone is not breathing, you have established the second cardinal sign of cardiac arrest. Of course, the third one is absence of pulse. You simply check a pulse in the neck with 2 or 3 fingers, locate the trachea, and put the fingers just to the side of the trachea. That's where you may be able to feel the carotid pulse. Usually you want to check a pulse on the side closest to you. Once you establish these 3 signs, you are good to start CPR with chest compressions. We will discuss chest compressions later, but let us learn how to do the assessment first. So I want 1 person in each group to the mannequin side, 1 person to the mannequin side in each group. Anyone can come to the mannequin side. It's practice time. Yes. Practice time. Come to the mannequin side.
Please, we don't want rushing. Please. Madam, please.
We are in groups of 4.
Please.
Each group of 4 has 1 mannequin. So 1 person in each group can come to the mannequin.
1.
Yeah.
Please.
And simply follow the video. Do what the video is doing, and we will go around and make sure you are doing that.
So let's begin. We'll start in 3, 2, 1.
Approach, assessing safety.
Hey, are you okay? Are you okay? Help! Someone help!
Shout for help. Check breathing. Check pulse.
Activate the emergency response and get an AED.
Say that. Get help and AED. Just say get help and AED.
Get help and AED, please.
Good. You can sit back. Before the next group, what you just did is trying to define whether the victim is in cardiac arrest. You want to be sure the scene is safe for you to perform CPR. You want to tap and shout, hey, hey, are you okay? Can you hear me? Help, someone help. Then you check breathing and pulse at the same time. This should not take you more than 10 seconds. If you don't find the victim breathing and you don't feel a pulse, he's in cardiac arrest. Say to the person that comes to help you, get help at AED. When you make requests during cardiac arrest, use what we call closed communication loop system. Closed communication loop system is the best communication system employed in medical practice, in the military, and in aviation, because it ensures that the correct thing is done at the correct time. The closed communication loop system has 4 elements. I did them when I did. Most of you did not even knew I did closed communication loop system. Use simple, specific, specified terms that are acknowledged. These are the 4 elements. Use simple terms. Hey, hey, are you okay? Can you hear me? Get help and AED. Who did I talk to? You? You? I talked to her directly. Yeah. How did you know I talked to her? I was pointing at her. I was looking at her. Isn't it? And that's closed communication loop system, except for one thing, she did not close the loop. To close the loop, she will acknowledge what I said. So she would say, I will get help at AED. Okay? Let me take that again. Hey, hey, are you okay? Can you hear me? He's in cardiac arrest and he needs CPR. And the best thing to do is for us to perform CPR on him. So please, I want you to get to A&E and shout for help, and come to ICU and collect the AED and come back to the scene. What did I say first? I said he's in cardiac arrest. Why was she not able to reproduce what I said? Because I did not use simple terms. I was using long sentences, too much. All I said was relevant to the patient, but they were too much to be taken in by my colleagues. So always use simple terms and use specific terms. I said get help and AED. These 2 terms are specific to help and AED. It's different from if I said, hey, hey, can you hear me? Can you hear me? He's in cardiac arrest. Do something. What something? What something? Something is vague. Okay? So it's not specific to anything. It may mean let her carry her car and go home. She has done something. Alright? But I need to ask my colleague to do whatever I want him to do specifically so that he will be able to do exactly that. All this is to make sure that within the 4 minutes window you have, you don't waste valuable sessions. Alright? So next group to perform the same thing.
Not the same person that did the first one. So another person in the group. Go forward. Another person in the group.
Follow the video.
So let's begin. We'll start in 3, 2, 1.
Approach.
Hey, are you okay? Are you okay? Help! Someone help!
Get up. Check breathing. Check pulse.
Activate the emergency response and get an AED.
Can you quickly, he's not breathing. Get him an AED. And then we start like this.
So let's begin. We'll start in 3, 2, 1. Hey, are you okay? Are you okay?
Hey,
Help! Someone help!
Can you hear me?
Activate the emergency response and get an AED.
Okay, quickly get the AED. And then we start.
So let's begin. We'll start in 3, 2, 1. Hey, are you okay? Are you okay? Help! Someone help!
Check breathing and pulse.
Activate the emergency response and get an AED.
Everybody can assist. It's very simple. Just tap and shout. Shout for help. Check breathing and pulse. No breathing, no pulse. Request for help at AED. AED stands for Automated External Defibrillator. It's a portable machine that can analyze heart rhythm and take you through until you shock a victim of cardiac arrest. Because electrical therapy is one of the definitive treatments for cardiac arrest. While BLS buys time until that definitive treatment is provided, you want to defibrillate the victim as soon as possible. So you said automated external defibrillator. Automated external defibrillator. Yes, sir.
What in a situation where you don't have AED? What do you do?
Yeah, we are talking about in-hospital settings. It is expected that the hospital should provide enough defibrillators for all units. If not for all units, but for high-risk units. But true, if you don't have the AED, continue the other steps of CPR until you have reasons to stop. And we will discuss those reasons in a little while.
Now let's practice chest compressions. Before we start, you need to make sure the victim is on a firm, flat surface, lying face up. If you need to remove any clothing from the front.
Chest compressions are the most important part of CPR. It drives blood and ends at getting a perfusion pressure enough to circulate blood through the vital organs. Some of the things we commonly wrongly do is that we want to compress the chest on the left side because we have this misconception that the heart is on the left side, and it is a very wide medical misconception. What happens is that the heart is in the center of the chest, between the sternum and the vertebral bodies behind, only that it is tilted this way, such that the apex is on the left and the base is on the right, and the bulk of the heart is still in the center of the chest. So please don't compress the left side of the chest, because if you do that, there are risks. They include rib fractures. There are higher risks for rib fractures if you compress on the ribs, not on the sternum. And rib fractures may occur on a costochondral joint, and it's a very difficult fracture to heal. The orthopedic surgeons will tell you that. Okay, so you don't want to cause anybody a costochondral fracture. You want to therefore compress the center of the chest. The normal positioning you want to take is put the heel of one hand on the center of the chest, just below the nipple line. That's the lower half of the sternum. Then put the other hand on top of the second and stand as close to the victim as possible, not far away from the victim. So you can use the weight of your shoulders right over your arms. All right? So let's get into position to perform chest compression. You are going to perform 3 sets of 30 chest compressions, pushing hard, fast, and allowing the chest to recoil. You want to allow the chest to recoil because you remember you are mimicking the systole, diastole of the heart. So if you don't allow the chest to recoil, it will not refill again. as much as you empty the hat, you also want it to get refilled. One person to the mannequin.
Again, one person from each group. That's the next person now.
One person to the
Okay, the imam doesn't want to do it. I know these people have done, at least I'm watching this group. Oh my God.
Everybody will do the same.
Everybody will go first.
Alright. Take your positions for chest compression. Put the heel of one hand on the center of the bare chest. Follow my instructions. Yes. Put the other hand on top of the second. You can interlace or straighten your fingers. Keep your elbows straight and your shoulders right over your arms. Remember to count with the video. Count out loud.
You ready? Here we go. In 3, 2, 1. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
Count out loud.
Count with the video. Count loud with the video.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
Good. Yeah, you can see back. I can see some of the victims are going to survive. Next group.
Next group.
Take your positions for chest compression. Put the heel of one hand on the center of the back.
3, 2, 1.
Count out loud.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
Take your position.
You know one thing that is very important. The depth is very important. So not just kissing the chest.
CPR assessment and providing chest compression. To give breath with the pocket mask. The pocket mask is better than the simple mask because it has a one-way valve. This diverts air, secretions, blood, or other things from the victim back to you. So it gives you some level of protection. It is the standard barrier device if you are a lone rescuer performing CPR. Meaning, even if there is bag mark system, don't use it if you are alone. You only want to use the bag mark system in 2 scenarios. Only 2 in the whole medical practice and nowhere else. If you are going to give rescue briefings for victims that have pulse but are not breathing adequately, or if you are 2 rescuers or more. So to give the breath with the pocket mask, you will see that the mask has a triangular disposition. Put the apex of the triangle on the bridge of the nose. It's your guide for correct positioning. Then cover the mouth with it. Then seal the mask with your index finger and thumb like this. And the other thumb will press on the lower margin of the mask like this. Be sure that you are not actually holding the soft tissues in the neck because you will close the airway. Another thing is you need to open the airway with a head tilt, chin lift, meaning that you want to extend the victim's head like this so the airway is open. Because for most victims who are unconscious, the tongue is going to fall back against the posterior pharyngeal wall, so air may not enter easily. So let's take our positions to practice the last skill in one rescue CPR, giving breath. One person to the mannequin.
Another person to come to the table.
One person to the mannequin.
Just one person.
When you give breath, please make sure the chest is right. Chest right is the most observable sign of effective breath. I hope everybody has gotten the secondary barrier, the baby wipe. Okay, what we want you to do is, this is the primary barrier between you and the victim, but we want you to put this like this. So when you give the breath, and take this away with you. Your colleague will put his on. This is to avoid contamination of students. Okay? Good. So, follow the video.
Get ready. Begin in 3, 2, 1.
Try the mask. Open the
Give
airway.
2 breaths.
Give 2
Watch for
breaths.
chest rise.
Give 2 breaths. Blow in.
Give 2 breaths.
Give 2 breaths.
See that the chest is right. Give 2 breaths. Extend it.
Give 2 breaths.
It's not moving.
Give 2 breaths.
To other side. Okay. Triangular should be at the nasal head. Okay. Nasal bridge. Yes. Remove the nylon.
And give 2 breaths.
Remove the nylon. The nylon number 3 is about. Nylon. Remove the nylon. Then you use the jaw. Stabilize your hand. Let it send your picture. Lift the jaw. Lift the jaw.
Yes.
Press it this way.
This should not be that.
Okay.
Only the mask.
Oh, it's only the mask.
Alright? Seal the mask. Like this. Okay? And this thumb. This pump is like, okay, give 2 breaths.
Yeah, it's not the way it's the lungs.
Right? Give 2 breaths.
So give 2 breaths.
1. You don't want to blow in the air.
Oh.
Empty yourself into it. Yes, 1. That's
Next, I'm trying to drink first.
Begin in 3, 2, 1.
Give 2 breaths. Watch for chest rise. Give 2 breaths. Give 2 breaths. Give 2 breaths. And give 2 breaths.
Very good, very good.
Three, 2, 1.
Give 2 breaths. Watch for chest rise. Give 2 breaths.
Give 2 breaths.
Give 2 breaths. Give 2 breaths. And give 2 breaths.
Come on, do it to let him snap. You want to take it.
All right. Now, finally, we want to put the 3 skills together and see how we can change a cardiac arrest victim. Let's sit back. Let's sit back.
Let's sit back. Now we're going to take the 3 skills together.
We are going to put together the 3 skills. We will make assessment, check pulse and breathing, request for help and AED, then start chest compression, give 30 chest compressions and 2 breaths. Okay, we'll give 3 cycles of 30 chest compressions and 2 breaths, inshallah. So 1 person to the mat. Okay. Just watch. Just watch. Just watch.
Now let's practice compressions and breaths together. Using your pocket mask for the one-way back.
When switching between giving compressions and breaths, limit the time between compression and breath cycles to less than 10 seconds. Make sure the chest rises with each breath, but provide ventilations just to the point of the chest rising. We'll start with assessment and then combine compressions and breaths. We'll be doing 3 sets of 30 compressions with 2 breaths.
We'll pause here to give you a moment to get into position with the mannequins.
All right, 1 person to the mannequin. And follow the video. Put this by the side.
Here we go. Begin in 3, 2, 1.
Follow the assessment, follow the video. Look at it.
Hey, are you okay? Are you okay? Help. Someone help.
Breathing and pulse. Chest breathing and pulse.
Activate the emergency response.
Just get help with AED. Start chest compression.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13,
Allow the chest to
15,
recoil.
16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
Give 2 breaths with the mask. 1, 2. Start chest compression again.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20,
21, 22, 23,
24, 25, 26, 27, 28, 29, 30.
Give 2 breaths.
Yes.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
Extend, open the airway.
Right. Next side. Next side.
Right, let's set our final set. Let's better enter this group.
Here we go. Begin in 3, 2, 1.
Assessing safety. Tap and shout.
Hey, are you okay? Are you okay? Help. Someone help.
Someone help.
Check breathing. Check pulse.
Give me the AED.
Activate the emergency response and give them the ED.
Start chest compression.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
Give 2 breaths, have 10 seconds.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
What we've just learned is called one rescuer adult CPR. There are other scenarios through the course, but my time is up and we may have to stop here. There are other scenarios taking you through how to operate the AED, what to do if you are 2 rescuers, what to do if you are treating a child, what to do if you are treating an infant, and how to help victims of stroking, and then other special situations concerning CPR. So we have to stop here, but someone asked, what should you do if there is no AED? And what you should be doing is exactly this: 1 rescuer or 2 rescuer CPR until you have reason to stop the CPR. Why should we stop CPR? That. Keep giving the cycles. Each 30 chest compression and 2 breaths is called 1 CPR cycle. Each 30 chest compressions and 2 breaths is called 1 CPR cycle. Keep giving the cycles until you have reasons to stop. Reason number 1, if the victim responds. Okay? A victim that was unconscious, was not breathing, has no pulse, or you are doing chest compression and breaths, and he starts moving, he starts breathing, you can stop. Don't say, remain cool now. Just stop, all right? We call that return of spontaneous circulation, ROSC, R-O-S-C. So with return of spontaneous circulation, you may stop CPR. Another reason is if the scene becomes unsafe. Remember, you started by checking scene safety. If the scene becomes unsafe, you may have to stop. All right? One day, this man brought his young wife to the A&E. As they were waiting in the waiting area, she collapsed. And staff started CPR around. And the man left. Nobody knew what he left to do. Only for him to be seen coming back with his wheel spanner. If you are the one, will you continue? I'm sure you will not continue. Okay, so once the scene is unsafe for you for any reason, fire or things like that, you may have to stop. That's one other reason you may stop. Of course, you also will stop CPR if you are presented with DNAR. DNAR stands for Do Not Attempt Resuscitation. It is an order that is given in advance by the victim himself, that in case I go into cardiac arrest, don't perform CPR on me. Is that euthanasia? No. Because he would have been guided by the physician that looking at all the things surrounding his sickness, there would be no need to perform CPR in him. I'll give you a scenario. I had a victim that was 108 years old with advanced CA bladder that has metastasized to the central nervous system. It gave him stroke-like symptoms. In the last 5 years, he has been bedridden, unable to do anything for himself, depending on others to take care of him. If you are managing such victims, you need to discuss with them about writing their will, about repentance, about istighfar, about the need for no CPR if they go into spontaneous cardiac arrest. If they understand you and consented, then you may take a written consent. Their witness will sign. Their witness should usually be the next of kin. Who is the next of kin? You have not yet mentioned anyone next of kin. Yes, who is the next of kin? That one has equal chance with the youngest. It's just that the Zakari has been saying. So who is the next of kin? The next of kin is the person assigned by the victim. So when we take next of kin on our medical record, usually you will see someone that can never even be seen anywhere around the victim. He's the one you will write his number. When you call, Barin Tambayu. You want someone assigned by the victim when he comes first to the hospital on the file. So the next of kin will countersign. And if that is done, then DNR can be provided by you, the physician, that in case this patient goes into cardiac arrest, do not resuscitate. But DNR does not preclude other things like all types of medical care, inotropic support, ventilatory support, IV fluid, NG tube feeding. Everything must be provided. All the nursing care, all the physiotherapy he needs must be given. Because if you omit anything from his treatment and he goes into cardiac arrest, it means you have killed him. You are now liable. All right? But if despite all your care, medical wise, nursing wise, other supportive care, he still went into cardiac arrest, then DNR will call because he has consented. And it is not euthanasia because that was not the intention, and that was the definition, the first keyword in the definition of euthanasia. Other reasons why you may stop CPR is if you become exhausted. You, the healthcare provider, become exhausted. Please mark the word. Exhausted, not tired. We are all tired here, isn't it? But we did CPR, isn't it? And most of the victims survive. But if you become exhausted, you cannot do CPR. Okay, if you are tired and you are saying 9, 10, 11, 12, 13, you are tired, okay? Continue CPR. But if you start saying 21, 22, if you find yourself taking 2 or 3 breaths in between chest compressions, please stop. Because we don't want you to say 29 and collapse. Another reason why you may stop CPR, very important reason, please listen, is if the victim is dead. You may stop if the victim is dead. Now, that victim was unconscious, not breathing, and had no pulse. And we started CPR, isn't it? That means because of these 3 reasons, he was not dead. And what concerns me now is that most of our death certifications will only carry these signs. And if I'm on a panel, and you are presented that someone died of cardiac arrest, I mean, you certify someone dead, and I check the mortality note, and it's only these 3 signs, I will send you to it. Because he was not dead, he was only in cardiac arrest. We should be very careful, especially those of us in the ER, emergency rooms. Because patients are brought in, and all you do is brought in there. Assessment, on examination, not conscious, no breathing, no pulse, no respiratory efforts, no pulse. Assessment, clinically dead, you killed him. Yes, you did. Because those were not the signs of death. These are signs of cardiac arrest. So what are the signs of death that may tell you stop CPR? They include 1, lividity. Usually the pathologist will tell us that, mostly. And if you are used to taking care of patients, especially in the intensive care units, you would know when they are living if you are performing CPR, or when they still have skeletal muscle tone. Lividity is global atony of the skeletal muscles, and you will have a feel that this body is actually living. It's an early sign of death. Next is loss of smooth muscle function. Smooth muscle function later. If you find someone whose pupils have become thick dilated to incident light, it's a sign that the iris muscles have lost tone and are not alive. And such are reasons for you to believe that the victim may not actually survive any quality of CPR. Or if you are performing chest compression and you start seeing all the gastric contents, the stomach contents regurgitating passively, it's a sign that the lower esophageal sphincter has lost tone, and you may stop CPR because once the lower esophageal sphincter, which is a smooth muscle, has lost tone, it's not likely that victim is going to survive. All right? So these are some of the few reasons why you can stop CPR, as asked by one of you, and that has brought me to the end of what we have for today. وآخر دعوانا أن الحمد لله رب العالمين سبحانك اللهم وبحمدك أشهد أن لا إله إلا أنت نستغفرك ونتوب
In the developed world,
CPRs are performed even by bystanders, and they save lives. So for IMAN to initiate this program, I think it's the way forward. Not for only IMAN, but I think for the whole hospital. So I will suggest that amongst us, if we have some of the officials of the hospital, this should be taken more seriously so that we have the whole package or full package of this program, from the basic life support. This is just an initiation to the complete basic life support and then advanced life support, so that each and every one of us will be skillful in performing some of this to our patients. And I would like to appreciate the facilitators for having the time to come all the way from Kano, and we wish them the safe journey back home, and all of us that are here, I hope the knowledge we gain will put it into use, and I hope all of us will go back home safely. Thank you very much.
Takbir. We're going to take another person to give us just a few brief comments. Sorry, please call on Professor Bugaji to just give us a comment on it.
Bismillahirrahmanirrahim. Sallallahu ala nabiyyina Muhammad wa ala alihi wa sahbihi wa sallam. I think all has been said. Just to once again thank IMAN for organizing this program. It's a really important aspect that not only medical workers, but any person that has to do with human beings should have this basic skill. And I think it will go a long way if our hospital here will acquire some of these mannequins and to do this, because in advanced places like in the UK, for instance, they do it on a continuous basis. Once you are working in the hospital, you must have that basic skill of how to resuscitate somebody who collapses. And I think that IMAN should invite our brothers to come back and give us the full course. This is a training course that takes at least 5 days for you to have the complete basic life support and then advanced life support. And perhaps they could include pediatric life support, because there is a little bit of differences between resuscitating a child, in particular a neonate, and an adult. Because whereas in adults they have cardiac arrest as the main thing, pediatric patients, in particular neonates, they tend to have a respiratory arrest. And what you need to do is to try to get them to breathe. So giving rescue breath for them is the most important thing. So thank you very much for this very, very important course, which everybody that is working within the hospital environment should be, have knowledge on. And it will go a long way if it can be done, not just for those who are newly employed, as you do in your setting, but to do a continuous training and retraining of even the old staff, because I think it's a very important aspect. So we wish you a very safe journey back to your destination. May Allah guide and protect you. Assalamu alaikum wa rahmatullahi wa barakatuh. Assalamu alaikum wa rahmatullahi. Other speakers have already given a closing remark which has actually summarized all what I only want to thank them in connecting IMAN for organizing the program, and want to congratulate them, especially the organizers and the facilitators for a successful program, which was actually stimulating. It has actually stimulated us and awakened us to the importance of this CPR. And as I have said, we hope IMAN will be able to also pursue it, or to continue to organize, like they have mentioned, this program, especially for the newly employed staff in this hospital. As we have heard the importance of this program, we hope
IMANBUTH tribe and be organizing such programs for newly employed staff. And I pray that this knowledge we have gotten today will be useful to all of us. And I want to appeal that we should try and share it with others and encourage them to have such trainings, especially when it is being organized here in this hospital. Thank you.
Thank the Almighty Allah for the opportunity given to us to plan and implement this program. It is the will of Allah. We thank you very much. And I pray it will be of beneficiary to all of us and humanity. On that note, I want to thank the chairman of today's occasion and the members of High Tables, Professor Garpo. I don't want to say much about him. He has made this occasion very lively. And our Amir, the special guest of honor, the giant of pharmacists, the and the head of department of medicine, the pediatricians. They have added a note. We need to have a pediatric so that we will not use all our weight because you need it. And of course, our facilitators is wonderful. It's wonderful. It's only Allah that will reward you. Continue sharing the knowledge. You are saving so many lives. And God will continue to save the life of humanity. God will bless you. And of course, if you all of us are here, you are not here. All of us, the participants are not here. You cannot speak to the here. You are staying here, you are patient, to listen and acquire the skills and knowledge. I pray it will be a great benefit to all of us. We say this on our era. May Allah grant us safe journey to our various homes. Assalamu alaikum.
Please. You may say, I have faith. I have faith. How many doors does Al-Jannah has? Do you know the number? It will be part of the quiz question. Better answer now. It has 8 doors. If they ask you to enter through the doors, won't you be happy? Will you want to enter through one door only? How many levels has Jannah? 1,100 levels. Do you want to start level 1? Level 2? Level 90? Level 99? Aha. So lan tanalu birra hatta tunfiqu mimma tuhibbun. You cannot attain to that level until you spend of that which you have. So if you have even donated before, it's not haram to redonate. Do you understand? And so that your name appears 2 times, 3 times, 4 times, mashallah. Then when the Malaikas are calling the register, they say, hey, Gawana Muhammad Mustafa, Kamaso Gomani, Dala Bismillah, So please, we are very grateful to all of us, especially for the medical outreach. It was a very hectic program, but we thank all of you. We thank our surgeons. They finished the surgeries like last night yesterday. There's nothing on the anesthetists, all of everybody that have contributed online. The community, they are praying, and I pray their prayers, our spirits will not reject their prayers. I pray Allah will make the prayers to be beneficial to us. So just like the statements have been made, these programs are continuous. The patient care training workshop, by design, supposed to take place quarterly. But because of lack of funds, that is why it became annually. So when we become more active in contributing to the Ummah, some of us have ministers, senators, etc. Let us get across to them. You know what you are seeing. You've seen, and Alhamdulillah, the newspapers are carrying the reports. You will have seen the Al-Majri program, you will have seen the outreaches. Alhamdulillah, get it across to your uncles, brothers who can fund these programs. Even if they want to monitor it, so be it. If you want to treat 100 patients, tell us 100 patients, 20,000 per one. When we do it, you send the money. MashaAllah. Do you understand now? And I pray may Allah make it easy for us. Please don't forget Salatul Asr. For those of us that have not prayed Salatul Asr, we go to the masjid and pray. Don't go home first so that you don't forget and start evening food. اللهم اهدنا فيما هديت وعافينا فيما عافيت وتولنا فيما توليت وبارك لنا فيما أعطيت وقنا اصرف عنا شر ما قضيت فإنك تقضي ولا يقضى عليك إنه لا يذل ما وليت ولا يعز من عاديت تباركت ربنا وتعاليت نستغفرك ونتوب إليك اللهم انصرنا ولا تنصر علينا اللهم امكر لنا ولا تمكر علينا اللهم زدنا ولا تنقصنا برحمتك يا ارحم الراحمين اللهم استجب دعانا واشف مرضانا وارحم موتانا اللهم صل على محمد وعلى ال محمد كما صليت على ابراهيم وعلى ابراهيم وبارك على محمد وعلى ال محمد كما باركت على ابراهيم وعلى ابراهيم انك حميد مجيد سبحان ربك رب العزه عما يصفون والسلام على المرسلين والحمد لله رب العالمين سبحانك بحمدك نشهد ان لا اله الا انت نستغفرك ونتوب السلام عليكم ورحمه الله